And then the other half was medical, so it could be organ failure, drug withdrawal, it could be a myriad, pretty much a little bit of everything, jack of all trades. And during that time, I worked as a charge nurse, which was kind of like the head nurse on the floor, and we were part of the code team. So if anyone died in the hospital or was trying to die in the hospital, I would go down and do chest compressions. So I saw a lot of death, and sometimes we were able to save them, but I think it helped me see kind of all sides of death. You know, sometimes we have patients who were full code, meaning they wanted all of those interventions, they wanted CPR, and then 2 doors down, they might have said, no, I don't want that, and they were actively dying, family was by their side, they went peacefully, and so it was kind of this interesting dynamic where at one point in the night I might see a traumatic death, and the other part of the night I would see a very peaceful death. So that kind of, over the years, COVID happened, and I was at the hospital through COVID, and then I said, I think I want to try hospice. So I went to hospice, I worked in the field for quite a few years. Feels like COVID was yesterday, but that's 6 years. It's weird. And then I hurt my back, and so now I educate, and I actually love it, so I feel like it was a blessing. So it's weird because I love to talk about death, but I think when you've seen traumatic death, there's something very peaceful about just imagining a death that could be full of love and joy, you know, and grief. So we're going to talk about that today a little bit. We'll talk about the philosophy of what hospice is, and also palliative care and where palliative care fits in and the whole frame of things. We'll talk about methods of comfort, how we keep people comfortable when they're dying, and then I want to empower you in having control of the dying process for yourself and kind of start thinking about that. I think Western culture, we don't like to talk about death. It's weird and scary for a lot of people, but I think the more we talk about it, the more we normalize it, the more we speak about it with our families and share our wishes, it becomes less scary, and it can be actually a beautiful thing. I think death is a lot like birth, but there's just a little bit more grief in there because when you leave, the family's sad, right? But so we'll get into that a little bit, but so Confluence Health is where I work. Our mission is to provide local care to and for our community. And have you guys seen the weird AI generated thing on Facebook? Anybody posting that? I did that, and that was what popped up for my house. My husband's like, don't share that, everyone's gonna be mad you're sharing AI. I was like, I know. Well, it's kind of funny. Okay, so let's talk about, I'm not gonna touch too deeply on palliative care because that's not my field of expertise, but I want you to understand where curative, palliative, and hospice fits in. So curative care is when you're born to when you're really sick, and you're seeking all forms of treatment so that you can be either you can prevent illness, you can treat illness, or you can cure illness. That's curative care. So, you know, you fall, you break your arm, you go into the ER, they fix it, curative care. You have cancer, you're getting chemotherapy, you're getting radiation, that's curative care. You have renal disease, your kidneys are failing, you get dialysis, that's curative care. So anytime you are receiving a treatment in which it is trying to reverse, treat, or cure, that's curative. Any questions on curative? It's very important that we understand that distinction. Palliative care is, you can still be receiving curative care. However, you might be very sick and having a lot of symptoms that need to be managed, and it can be very complex. So let's say you have, you know, end-stage kidney disease and you're receiving dialysis, and you're having a lot of symptoms with dizziness, edema, swelling, or let's say you have cancer and you're receiving chemo and you're having a lot of pain symptoms, that is very difficult to manage, and so it might be better to see a palliative provider who can really adjust and knows all the different types of pain management. So that's palliative care. So you can be receiving curative while on palliative. Now, the line where it goes from palliative to hospice is when someone no longer either benefits from curative treatment, so they no longer benefit from chemo, radiation, dialysis, whatever treatment you're receiving, or they're sick of it and they've had enough and they're choosing to opt out of it. Once that time happens that they just want to focus on comfort, that's when hospice can come on board. So hospice cannot provide cares while you're also receiving curative care. So that's the hospice philosophy, is we're focusing on comfort and allowing the natural trajectory of death to occur and supporting you in that process. Any questions on that? Yes?
So if you are in hospice, then you wouldn't have palliative care.
Right. Yeah, it's kind of a good segue. So a lot of times the palliative provider, if you're in an appointment, for instance, and you're like, I'm sick of going to chemo and throwing up all the time. I don't want to do it anymore. I'm just sick of it. And then that might open this conversation where they say, well, maybe you'd be appropriate for hospice. The other, well, we'll get into the, you have to qualify for hospice, but yeah, does that answer your question? Any other questions? Okay. So I wanted to talk a little bit about Dame Cicely, or Dom Cicely Saunders. She was the founder of hospice, and she was a very amazing woman. She first was a social worker. At the time, it wasn't called a social worker, but that was her role. Then she became a registered nurse, and then she went on to become a physician. And she founded the first hospice in London in the 1960s, and then was invited to, I believe it was Yale University. And shortly thereafter, they opened their first hospice here in the U.S. in 1971. So it's really not that old. Like, when I think, I mean, obviously it's all I've ever known, right? But it hasn't been around a super long time. I think even in my lifetime, in your lifetime, we might see some more changes with how hospice is run, but I think we've got it down pretty good. So that's Dame Cicely Saunders. She also reminds me of Mrs. Doubtfire a little bit. And in a BBC interview, the interviewer asked, can you actually take the sting out of death? And she said, I don't think you can take the sting of parting, but you can do a lot of things to make that parting easier, to bring out the strengths in the family who are going to live on afterwards, and indeed in the patient himself or herself. So that, over and over again, we have people saying to us, it seems extraordinary, but that was one of the best times we ever had. And that's our goal in hospice, is that we want to foster a time that serves the patient, in which they want, they lay out their framework of how they want to die, how the last 6 months to a year of their life wants to look like, and we support them in that. So
What happens when the patient can't do that? I mean, themselves.
right. So hopefully, that's why I'm here today, that we encourage people to think ahead, so that, when that time comes, they have it written down, and family can follow their wishes, their written wishes, or even with conversation with family. But in times where maybe that what didn't occur or wasn't a possibility, then we just go by the family's wishes. And sometimes people don't have any family, and then we just assess the patient, make sure that they're as comfortable as we can get them, while also having a really good quality of life. So that is how we do that. So what's hospice? Hospice is reimbursed by insurance. So we provide services and we receive reimbursement from insurance. Primarily we're reimbursed by Medicare, so the majority of our patients are on Medicare. However, other insurances cover hospice services as well. We cover the medications related to their terminal illness. So whatever illness is causing them to be so sick that they need hospice, and any medication that they're receiving for that illness, we'll cover. Also, any medication that is related to comfort. So if they're on a bunch of bowel medications because they're struggling with constipation, we'll cover all of those things, or pain medication. So if you're receiving any medication that is curative in nature, then we would not cover that and pull that. But let's say you're on insulin and that's part of your daily routine. You've been on it for 15 years. We'll cover that because taking you off could cause discomfort. It just depends on the patient, right? So if they are saying, oh, I'll just stay on my diabetes medication, then we'll cover that. But some patients also say, I don't want to poke myself anymore. I don't want to worry about it. I don't want any more lab draws. Then we say, okay, we don't have to. So that's kind of how that goes. And then who is part of our hospice team? Our team is huge. So we have the registered nurse, which is the case manager, the nurse case manager. And they essentially are the face of hospice. You're going to see them the most when you're on hospice. They come out generally at least weekly, up to daily. So when you're if someone's in actively dying stage, we'll be out there daily. It kind of just depends.
Are most cases a home care hospice?
We'll get into that a little bit, but yeah, no, yes and no. We have hospice anywhere. We have a slide on it. And then the hospice physician is involved. They are who the nurse receives all the orders from. They generally are running the show, so the nurse goes out, they're the eyes and ears for you, or whoever is on hospice. And hopefully it's not you. Yes.
Typically, how many patients does an individual nurse see, like?
In a day?
In a day. Or is there such a thing?
If they're a 8-hour nurse in a day, they would see about 5 or 6. And then if you're a 10-hour nurse, you would see 6 to 8.
Oh, okay, thank you.
Yeah, so their visits are generally an hour. Sometimes shorter, if things are going okay, if they get there and there's really no symptom issues going on, everything's kind of status quo, shorter. If they get there and pain is horrendous, you're having all kinds of symptoms, then it could be as long as it takes for them to get a plan in place to manage those symptoms. And then your primary attending, so it could be your PCP, your primary care provider, stays in the loop if you want them to be, and we just kind of keep them abreast of everything that's going on. If you have a fall, for instance, we'll let them know, or if there's something huge event, or if you start to transition to actively dying, we'll let them know. And it's just good to keep that relationship in case we have to ask them any historical questions about you, for instance. And then we have a chaplain or spiritual counselor, and he is there to support the patient and the family, and he doesn't go in with any religion. He just goes and meets the patient where they're at, so it could be a Buddhist, it could be a Christian, it could be a Mormon, it could be anyone, and he just kind of meets them where they're at and goes from there. And we also have social work involved, so let's say there's some concerns with caregiver support, or their family's asking, how can we get more support in here for my mom or my dad? The social worker is involved and they can help with that. We have bereavement counselor, and that's Christy Karpenko. She also runs our volunteer program, which is very robust. They're generally retired medical professionals that are on our team, but it could be anyone that is interested in volunteer, and they make phone calls and check in with patients. They also can go out and play like chess, cribbage, read poetry, read the Bible, whatever it may be. They go out and support. That would be a non-medical side of hospice. And then we have home health aides, and they are we call them our bath aides. So they can go out for an appointment and provide a shower or a bath, and more like supplementary, can't say that. So it's like probably like 2 times a week, 1 to 2 times a week, and then besides that, the caregiver would step in if they need more showers. And then we have physical therapy and occupational therapy, and that seems a little weird, right? Because that is that curative care, but when we think about therapy for hospice patients, we change our mindset a little bit, and we're focusing not so much on the long term, but on our short term goals. So let's say the patient wants to go to a family reunion in Idaho, and they're going to go in their RV, but they're worried that they can't quite make that step into that RV. Are they strong enough to do that? Can they use the bathroom safely when they have a walker they need to use? So that's when we would pull therapy in and help the patient meet that goal so that they can have quality of life. So that is where they come in. Any questions on our team? Yeah.
With regard to special beds in the home or other equipment, and also a person who might come in and help the caregiver with housework.
Yes, so we do, we rent, so hospice rents equipment through Bellevue Healthcare, and then Medicare reimburses us for that rental. So it's not a permit, we're not giving anything, but we're allowing you to rent that. And it's usually beds, it can be walkers, wheelchairs, toilet risers, all kinds of things, kind of pretty much anything you can think of, unless it's extremely fancy. We will cover that. The bath aide can do some household tasks. Generally speaking, they don't do a ton of that. There's kind of a line, but they could take out garbage, for instance. They could make the bed. They could throw laundry in. That could all be on there, but it's not. We don't provide, let's say you have someone who needs 24/7 care. You can't really leave them safely. They're needing to be turned every 2 hours. They are going in grease or diaper, and they need to be cleaned up. We don't provide the minute-to-minute, hour-by-hour care. So when you think of hospice, think of us as all of these little team members, and instead of the patient going out for an appointment, our team members are coming to you for appointments. So we come in for short periods and just check in with you, make sure symptoms are well managed, that all your needs are met, you're safe, clean, you're comfortable, but we can't stay and provide that long-term, day-by-day care.
Would volunteers be doing like nail care or shaving or hair trimming or shampooing?
So the aide can do, I need to check on nail care. I think they can do nail care. I think they can. My background's inpatient and they never let us do it because of diabetes. They think we're gonna cause horrible infections or something crazy. But I believe they can do nail care. They certainly can wash hair, they can help with shaving, they can shave heads, but they're not hairdressers, so if you want something cute, probably
Might
not.
be volunteer.
You might not want Edgar to come out and do your hair. Yes.
So, let's say you're in home and hospice, so, and you don't have enough help to take care of you, so who determines that you would go to like assisted living?
That's a good question. So that can be the patient deciding if the person who's ill and can't take care of themselves can identify that for themselves. Sometimes it's a matter of the family saying, hey, you can't. Sometimes it happens where a patient comes onto hospice and they're living independently, but as a hospice provider, we know eventually they're going to be so sick that they can't take care of themselves. We can't take care of ourselves when we're actively dying. So we're thinking ahead and starting to have those conversations. What is your plan for when you can't care for yourself? So it's it just depends on when you come into hospice. If you're on hospice early enough and that transition happens, we'll help identify that for you. If we're noticing, you're falling a lot more, we get there and you're not, you have dirty briefs on and you're not able to care for yourself, you haven't eaten in 24 hours, we notice your medications haven't been taken, we start to put those pieces together and say, I think we need to get some caregiver support. Some that is, you know, the social worker finding, what you qualify for, and sometimes caregivers can come in and your insurance will cover a certain amount of caregiver hours. Sometimes family opts to come and provide that care, and sometimes people say, you know, I think I can financially handle going to an assisted living or a long-term care.
So you don't need a doctor's order or anything like that?
No.
One more.
Yes.
It has to do with respite for an in-home caregiver when the patient is living in your home. And I understand that the patient can go to the hospital for respite for the care and remain on hospice if it's just for a specific time. You may be addressing that later.
Yes, we will get to that.
Okay.
If more questions come up on that, though, let me know.
Yeah.
Okay, any more questions on this, on the members of our team? Okay. So why might someone be on hospice? We kind of have covered this, but we're out there to support the patient and the family. We are kind of a blessing to a lot of people because we allow them to stay in their home, wherever that might be. A lot of our patients are so sick of the hospital, they don't want to step another foot into that hospital, and they are just so happy that they also don't have to go to the doctor's appointment. That can be very burdensome for a lot of people. So that's a pro, is having us come to you. Prevention and relief of suffering. We are thinking ahead about every illness that they have and what could come with that illness. What can we expect to occur? And we have a plan in place for that. And then early identification and assessment of pain and other issues, similar to what I just covered. So who receives hospice? We cover for Confluence Health, we cover all of Douglas and Chelan County. So that's actually a very large area. It's all the way up to Bridgeport, kind of near just before Quincy, way out into Lake Wenatchee, off the pass. So we're all over the place, and we cover a large area. There's also a newer hospice that covers Grant County, and that is Advanced. And they're a newer hospice to our valley. Who receives hospice? So we have not discussed this, but I think probably you know this already. You have to have a terminal illness to qualify for hospice. So that means that a medical provider has said that, if your disease follows its normal trajectory, we estimate that you have a life expectancy of 6 months or less. Now, sometimes patients come on and they live past 6 months, right? Because we don't have a crystal ball, we don't know everything. We give our best guess. Sometimes it's even that they get a little bit better because they're on hospice, because we're watching them so closely, we're in there adjusting medications, tweaking things. It might be that they're no longer taking chemo that they weren't tolerating very well, and now they're able to eat more and sustain life a little bit better. So we're not going to kick anyone out if you have a terminal illness and you are with us for longer than 6 months. We're just going to watch and make sure that you are still sick enough to be on hospice. And we follow an LCD guideline, and that basically just means that we have certain criteria that each person needs to meet based on their primary diagnosis. So like heart failure, renal failure, cancer, they all have their own check boxes that you have to meet to qualify, and that just makes it so that everyone in the U.S. is following the same guidelines, so we don't have people at various stages of their illness coming on to hospice. It kind of keeps us all even. And also, it doesn't matter if you have a pulse form or not. Honestly, we're going to touch on that today, and hopefully everyone will have a pulse form when they come on to hospice. Who here knows what a pulse form is?
I filled one out yesterday.
Two,
for my
okay.
mom.
We're going to touch on that. Essentially,
And
that.
hopefully hospice won't lose it this time.
I know. Those, you wouldn't think you could lose a bright green form. This is what it looks like, but it happens.
It was
so-
even scanned into the system, and nobody could find it after that.
Oh no. So, that form it is a cheat, I call it a cheat sheet for medical professionals, so if you call an ambulance, for instance, and that's hanging on your fridge, they're gonna look at that. And it tells them whether or not you want CPR, are you wanting, an airway, like be intubated if you can't breathe? Are you wanting life-sustaining treatment, or are you wanting to just focus on comfort? That's what the pool's for, and we'll touch on that a little bit more. When I mentioned the check boxes, the LCD guidelines, they're looking at the clinical status, symptoms, signs of their disease, labs. Essentially, we're looking not only at the patient and what we see, but we're also looking at the hard, fast data. And we have to have all of that together to prove to insurance that you qualify for hospice. So, it's important for us as hospice providers and professionals to understand trajectories of illness. So every illness can have a different trajectory, typically. So this is a graph that kind of shows the different trajectories. The baby blue line, dotted line, shows like a sudden cardiac arrest, that they're doing okay and then suddenly they die. Obviously hospice probably won't be involved in those cases. But the dark blue line, that is our cancer, and typically they're doing okay. It might decline slightly, but eventually they'll plummet, and then they'll really need it. So we want to make sure those patients come onto service when they might think, I don't know if I really need you yet. But if the doctor says, you have a terminal illness, and they no longer want curative care, that's a good time to come on hospice so that we can be there when they really plummet. And then that sawtooth, the orangish red line, that is like organ failure, so cardiac failure. Your heart is failing. Sometimes you're doing really well and you don't have a lot of swelling, you don't have a lot of shortness of breath, you feel like you can do most things, but then you really tank and you're having a lot of symptoms and you're swollen up, you're having to take a bunch of water pills, you're having a ton of shortness of breath, and you go to the hospital and they tune you back up, and then you might go back up a little bit, so you're doing well, you plummet, go to the doctor, they tune you up, then you might get a little bit better, but you never quite return back to where you were before. So that's organ failure, and eventually they'll decline so far that they're needing care 24/7. And then the green line is a dwindle, we call it a dwindler, and that would be like our Alzheimer's patients, for instance, where they could be someone who has an illness for years and years and years, and they just little by little are declining and getting sicker and sicker. These are our hospice providers that we have at Confluence Health. Dr. McBride, Chad McBride, Charles McCormick, and Lisa Caltabiano. Does anyone here recognize any of them?
Dr. McBride.
He's a nice one. They're all very nice. And Charles McCormick also works for Palliative Care, so he bounces back and forth. And then I believe Chad McBride also works for geriatrics. Okay, Connie. So where does hospice occur? It's anywhere the patient lives, essentially. So it could be a private residence, their own home. It could be an assisted living, a long-term care facility, a skilled nursing facility. It could be a group home. It could be a shelter. I had a patient down the end of the Ave. What is that, Mission? I think it's called the Mission.
Mission.
Yes, yeah, I had a patient there. It can be respite, so if a patient, let's say they're needing 24/7 care and their caregiver needs to go out of town for their daughter's wedding or something, they might say, we need to use our respite benefit. So hospice patients qualify for 5 days of respite care, usually every couple of months. It's every so often, kind of vague. And sometimes people will use that a couple times while they're on hospice. Sometimes they choose not to, because if the patient has dementia, for instance, changing environment can cause more discomfort. So it just kind of depends on the patient and the situation. But we do provide respite, and typically we will have patients at the mayor's inpatient on the 3rd floor, and our nurse case manager will go out every day and just check in and make sure everything's going okay, the patient is comfortable, and that there aren't any symptoms that we need to manage. Any questions on respite? No? You got it? And then we also have general inpatient, which is the highest reimbursement cost for hospice. And so we don't have to use it very often, but this would be if a patient, it typically is like a palliative care a patient who was a palliative care patient who has a lot of symptoms, and maybe they've been on a high dose of medications for years, and now they're getting sicker and sicker, and their symptoms are getting worse, and we're throwing everything at them, and it's not quite working. Sometimes we have to send them to the hospital for IV medication. We, as hospice, we can't place an IV into a patient because we're not there 24/7 to monitor that IV. So that's why we can't do that. If someone has a port in their chest where we can place a line straight into it, we could use that at home. So that's a plus. And we'll talk a little bit more as we go on what we can do to prevent having to send someone to the hospital. It's really a last-ditch effort, and it doesn't happen that often. It's just those very, very complicated cases. So reasons someone might come off of hospice is to pursue curative treatment. Maybe a new clinical trial came out and they're like, oh, I want to try that, and they would come off of hospice so they can pursue that. Or if they change their mind and they want to go back on dialysis, for instance, they can always revoke hospice. Obviously, if you die, you would discharge from hospice. If you're no longer terminally ill, so you might hear someone graduated off of hospice, and that's usually like an organ failure or a dementia patient who maybe we got them onto hospice a little too early, and maybe it was that sawtooth trajectory. They were kind of in a valley and they were looking really bad, but we were out there all the time monitoring, changing meds, and now they're looking better. So then if they plateau for a long enough period, we might say, I don't think you quite need us anymore, but if you get sick again, then we'll bring you back onto hospice. So we might graduate people off of hospice, but then it's always an open door. We can come out and reassess to see if you re-qualify. If someone moves out of service area, obviously, and then if they want to change to a different hospice agency, then they would discharge from us. Oh, and also for cause, if let's say the environment's not safe for our staff to go out, if you have bears living underneath your deck, this has happened. No, we cannot come out, sorry. If you have drugs in your home that could be harmful to our staff, then we can come out. So I'm talking like illegal drugs. Let's see. What could be a barrier to hospice? It could be that maybe they don't have a safe care plan. So kind of like what you were asking about when someone isn't safe to care for themselves. If we show up and the patient's there alone, no caregiver, no family, and we know right off the bat, you cannot live safely on your own, we can't admit them to hospice until we can get a safe care plan in place for you. So we would contact your primary caregiver, we would get a case manager on, and we would figure out how to get you in a safe place, and then reevaluate for hospice, because we can't care for someone who doesn't have any support to implement the regimen in which we're encouraging or prescribing. Does that make sense? Fear of death can be a barrier. Feeling like they're a failure for choosing hospice, that we hear that sometimes. Misconceptions about what hospice is or is not. We're not out here to come kill anyone. We never prescribe medication beyond what we think is the bare minimum to manage that symptom. We're going to give you the lowest dose we can to manage that symptom. We're not out to give you so much morphine that you're sleeping all day. Unless you're at the point where you're uncomfortable all day long and you want to be sleeping, then we can sedate you. But we're never gonna come out and just give you all the medication and kill you. That's not in our job description. That's not part of the game.
It's not assisted suicide.
And then sometimes our physicians or the team can be a barrier if we have a lot of cooks in the kitchen and you're getting different ideas of where you're at in your disease trajectory. That can be very confusing and be a barrier. I think we covered what we don't cover. So room and board, where they live, like assisted living, long-term care, group home, hospice does not pay for that. Your caregiver support, we don't pay for that. Any care that you pursue that wasn't run through the hospice, you're at risk for having to pay out of pocket. So some of the specialties, if you want to go see a cardiologist, for instance, and you're on hospice, you're at risk for having to pay that bill because you're going to a specialist like that is in essence, you're stepping away from the philosophy of hospice and seeking curative treatment. And we can manage cardiac symptoms through hospice, so that's something to know. Any medication that isn't related to comfort or your primary diagnosis isn't covered by hospice. And I think that covers that. Any questions on anything else we might cover or not cover? Okay, this is the part I like to talk about most, is the dying process. I think a lot of people, some people know a little pieces of death, and sometimes it's little traumatic things that they picked up along the way. Sometimes they've been there for someone through their whole process of dying, and they might have kind of a well-rounded idea. I want to hear from you, how many of you have cared for someone in the last 7 days of life? Okay.
Oh, the last 7 days of life, no.
Yeah.
The last 7 days, yes.
Yeah, last 7 days. Yeah. Okay, so you have a good amount. How many of you are comfortable with death? Okay. How many of you are comfortable caring for someone who's dying? Okay. So we're going to talk about what to expect. A lot of times patient or family will ask hospice nurses when they're there, or even aides, how long do they have left? How much more time do we have? And we can't really give a definitive answer, right? Because we're not God, we're not a higher power, we don't have a crystal ball. But we generally know what symptoms or signs are tied to certain time frames, and we speak in weeks to months time frame, days to weeks, and hours to days. And that's generally how we try to word things, because it gives you a general ballpark idea of where we're at. Estimate idea. So we're going to talk a little bit about each of those areas and what things you can see. Oh, my on time. So for weeks to months, you might see increased hours of sleep. So this is when someone first comes on the hospice. We might see they're starting to withdraw a little bit more, spending more time at home or in their room, really not engaging in activities that they used to. They might put a sign on their door saying no visitors. They might have changes to their appetite, so that could be just a general decrease in appetite. It could be an unusual change, like they always had coffee every day at 7 a.m. and now coffee disgusts them. You might see that. They might start to not pick foods that are difficult to digest. So, think of foods that are hard to chew. So, meats, carnivorous vegetables, those are the first things to go, because if it's hard to chew, it's hard to digest, and maybe their body can't quite keep up with that. So they might opt for softer foods like puddings, ice cream, oatmeal, just soups in general. So you might see that. And they might start talking about their life in review, kind kind of just discussing
Or making up stories.
or
about
making
their
up
life.
stories, that happens too. So they might just be processing their life. I enjoy that stage, just listening to people's stories. And then days to weeks before death, we might see, again, sleeping more of the day. They might actually start flip-flopping their night and day. Not all the time, but sometimes. So they might be sleeping during the day and awake at night, and they don't seem to care. Kind of like, I'm awake at night, that's what's happening for me now. They might become more disoriented or confused, just a little bit different than their baseline. They might be ambivalent to the time of day, like I mentioned. They might start to prophesize or visualize death. So seeing people or speaking to others that are already dead. Who here knows what deathbed visioning is? Oh, I love talking about it. So this sounds very woo-woo, but I think it's because hospice healthcare providers don't really talk about it to just someone at their grocery store. So unless we're talking about hospice, we're not really talking about it. But deathbed visions are very common, and it's not a hallucination, and it can be a patient who's alert and oriented. So I had a patient, she would love that I was telling the story. She was sharp as a tack, and she was dying from heart failure, and she was having a lot of swelling problems and needing a lot of water pills to get her swelling down. So I went out to check on her and just see how that was going with the adjustment. And we're sitting there talking, having a normal conversation. And she says, Chelsah, can I ask you a question? I said, well, yeah, obviously, of course. She says, what does it mean if someone who's dead has been visiting you? And I said, oh, well, is it comforting or scary? That's our first question. And she said, it's comforting. I said, okay, well, that's probably a vision. And I said, well, who are you seeing? She said, my mother has been visiting me and cleaning and cooking. And she's sharp and she's alert and oriented, and we're having this conversation. So, that is what I would consider a deathbed vision. It's a comforting experience where they're seeing someone that maybe you or I aren't seeing, but if it's comforting, we allow them to live in that reality.
Or if they're seeing bighorn sheep in the bathroom.
If it's not scary. If it's
Wasn't.
scary, now that might be more of a hallucination. So if it's like mice running on the floor, spiders crawling on the walls, scary figures, that might fall into more of a hallucination. We want to assess, is it their labs askew causing that, or are they on serious medication that could cause hallucinations, and we will then adjust and pull back on certain medications to manage those hallucinations. But if someone says they're
So are
seeing,
those a good question to ask? Is it comforting or is it scary?
that's your first question, yeah.
Okay, cause that's helpful to know.
Yeah, because if it's comforting, why do we need to try to medicate that away,
Right.
right? It's like, hey, if you're seeing your dead child or your dead mother or your dead uncle, great, if that's comforting to you, we don't try to treat that.
How common is that?
That's pretty common.
And is it usually relatives that mean something to them, that
Yeah,
they
it's
feel like
usually-
they're face to face with again in some way?
Yeah, it's usually someone that had a strong connection with, while they were alive that is no longer alive.
The other
Sometimes
day,
it's
my
pets too.
My mom was looking for her dad. Her dad's been dead for more than 45 years. But it was her dad she was seeing.
Yep. So, yeah, and sometimes it's not that they're seeing him, it's that they're looking for him too. So that's kind of a metaphor for maybe where their illness is going. Let's see. Eventually, during days to weeks, we're gonna really see a decline in their intake. So you might not be eating or drinking very much at all. And, this can be very hard for family. Sometimes we'll get there and we'll see them trying to syringe fluid into their mouths, force feeding them food, and we just have to sit there and understand, put ourselves in the family's perspective, understand that they're trying to provide care for that loved one, and that's, when you're feeding a baby, you gotta feed a baby, you gotta hydrate a baby, you gotta keep them alive, right? So I think that's just human nature, but in the dying process, when we're not eating and drinking, it's our body's hardwired, we're hardwired to know how to die in a comfortable way. And so if you have so much food in your belly that you can't digest anymore, or you're drinking so much fluid that your body can't put it in the right spots and you're swelling, that's not a comfortable death. And so when someone isn't eating and drinking anymore, we just encourage the family, oh, their body's just doing what it needs to do, and we don't have to force it.
And how do you change the mindset of the person who is a consummate caregiver and who really it's like, she's starving to death, and I gotta keep doing this. How do you do that?
I think it's just a lot of re-education, a lot of discussion about why do you feel compelled, and maybe what other ways can you provide care and love to that loved one instead of force feeding or force hydrating. We see this a lot just right before end of life, but we see it for a longer period with our dementia patients. Because if you really force feed them, they'll eat for a long time and they'll live for a long time. But the reality is, as their body is shutting down, their brain is also shutting down, and it's stopping that cue. And if that patient doesn't look hungry or feel hungry, it's okay to not feed them. You know, if they're comfortable and they're on hospice, we don't have to force feed them. We can allow their body to do its natural thing and dwindle, and that's okay. So that's that's a hard one. I see that the hardest part is with those dementia caregivers, is when that line is drawn, because you don't want to neglect someone, right? So we're not saying don't feed them at all, but if they're not hungry and they're not really wanting to take the food, we're not going to force it. So it's just a lot of re-education, a lot of discussion of why we don't do that.
But then it comes sometimes, it's like, you're feeding them and they're saying they're hungry,
Oh, well, what?
but they can't swallow it.
Yeah.
That's another tough one.
So if they're on hospice, then we just feed them, and if they choke and die, it happens, unfortunately. But if they're
Okay.
going out they have that choice, and we're telling them, I don't know if you can handle this. Sometimes they do choke, and so they might end up with a pneumonia and die from that. Either way, they're on their trajectory of dying, right? So we just want to support them and provide what they are wanting and wishing for. So if they're choosing that, then we just continue to feed them, because they'll be happy to eat their ice cream and taste their ice cream, even if they can't swallow them. Yes.
Do you ever have hospice patients who decide that they just want to stop eating consciously?
Yes. Where's her name? I just was Googling it, because I always forget there's an acronym for it, but it's essentially, voluntary stopping of eating and drinking, I think is what it's called. And yes, so essentially sometimes very, very alert and oriented patients might opt for VSED, where they decide to stop eating or drinking, I guess what it's called. Now it's on TV, I'm not wrong. But they can choose to not eat or drink and eventually die from that. We do see that sometimes. We also see a high population that opt for what is it called? Now I'm brain dead. Where they want the medication to end their life. So, and that's legal in a certain amount of states in the US.
Assisted suicide, is that what you're
Yeah.
saying? And that's legal,
In Washington, yes.
but
Yeah.
not through hospice.
Right.
Can I ask?
Well, we don't provide it, and we don't advocate for it, we don't push for it. But there are patients who are on hospice who say, I've received the medication and I'm gonna opt for that. It definitely did.
I want to follow up with Diaz, what she was saying about her mother not wanting to, she was hungry, but she couldn't really eat. Now, that's kind of like comfort, right? Could you put a feeding tube on her mother?
No, because we've asked not to.
You've been told that.
Yeah, we've asked not to. that's part of the next step of in the care, on the care staff, and we have opted for not.
Okay.
Now, and
That was a family
that's a
decision.
great question, because what it ignites is a conversation about what's your goal. Is your goal to follow a normal trajectory towards death, or is your goal to implement treatments to provide life-sustaining measures?
Exactly, what's not gonna be comforting to her to have an IV, she's not gonna then have that sensation
Right.
of being
Yeah.
fed.
Yeah.
So,
It was
makes
confusing.
sense.
It is very confusing, but
Yeah.
you have to follow that train of thought and that logic through all the way of why are we placing this? Are they comfortable without it? Are they already on the trajectory of dying and this is a normal part of their disease process? So sometimes people come onto hospice and they have feeding tubes and eventually they either might not tolerate it anymore or they decide to stop. And that's also okay.
I'm sorry, my mother is using the hospice services
Yeah.
and has been for the last 2 weeks,
Yeah.
and we're just kind of watching to
You're
see.
in it.
Yeah, we're there. And my daughter, today is my daughter's 40th birthday, and she doesn't want her grandmother to die on her birthday.
Yeah.
So hopefully that won't happen.
Yeah, it's, any of those measures can be a tricky conversation, but you kind of have to follow that logic all the way through, and sometimes it's not black and white. Hospice is very gray, very gray. So it's just having that conversation with your team and really figuring out what's best for that patient. We might see changes in their blood pressure, any of their vital signs, but we don't really check them a whole lot unless we're worried that maybe a high heart rate is causing chest pain or something like that. We kind of try to stop looking at all the numbers and just treat what we're seeing and make that patient comfortable. We might see changes in color, body odor.
So they do have changes in color sometimes,
Sometimes,
like really red cheeks and.
yeah, so,
So
as you're
that's kind of a norm, the reason I asked is because has happened.
Yeah.
My sister, who just came a couple days ago, is worried about that, and I didn't know how to, and she didn't think to ask the nurse when she was there.
Yeah, so as your body shuts down, your brain, your thermal regulation kind of can stop working, and so people might have fevers, and that's normal, so that would cause flushing. So we just try to keep them comfortable, cover them if they're cold, take the blankets off, remove clothing if they're hot, put a fan maybe. If they're having like liver disease, then they might be yellow. If they're having cardiac issues, they might start turning blue. So you can kind of see a lot of different colors. We might see mottling where you almost see like reddish purple splotching of the skin, and that is usually really pretty close to death within 48 hours. You'll see decreased urine output because they're probably not drinking a whole lot. You'll hear the gurgle, and so that is where fluid is backing up and can't be processed all the way. It's more distressing to the family or surrounding people than it is the patient. That's something to know. We never suction out secretions because if you start putting foreign bodies in mouths, your body is going to do what? It's going to start to salivate and kick that foreign body out. So it can actually be causing more secretions by us trying to suck anything out of there. And the death rally. Who here knows what the death rally is? Couple. So the death rally is when, the death rally is when someone might suddenly, they might have been in bed, sleeping the majority of the time, really not communicating, not eating, not drinking for days. One day they wake up, they are trying to get out of bed, they say they want to have roast beef, they are eating, they're drinking, they're talking to family, and if we're not ready for it, family might have a false sense of hope where they think, oh, they're getting better, they're not dying. But if we know that this is a normal thing that can occur at end of life, then it can be a time of connection for our loved ones. Where we say, oh, this is a good chance for us to all sit and say what we need to say, have our last conversations, share our love rally is a real thing and can happen, and to have a good mindset around it where you're not, having false hope, but instead connecting. Any questions on that? Very special time. I really love to see when that happens, and I just say, well, thank you for calling and letting me know. I hope you spend a lot of time with them. Are you guys in a hurry to get out? Because I can go a little over, or we can end early. Keep going? If you have to leave, you can leave. So I think, let me see where I'm at. So I want to touch a little bit on, because you've had so many good questions, and I think we're going to run a little over an hour. We have a comfort kit. So this is our standing orders is what we call them. Essentially, we have a comfort kit that we order for every hospice patient when they come on to hospice, and it's like a little pharmacy in a bag of emergency medications to manage symptoms. So if you call us in the middle of the night and say, I'm having a lot of nausea, I have a ton of anxiety, I'm constipated for days, or my mom's hallucinating, we have medication in here that we can have the caregiver pull out and administer. So that's the comfort kit. We provide comfort through oral medication, transdermal, so patches on the skin, and sometimes through people's port with a CAD pump, a little portable pump that can give medication. And sometimes we do palliative sedate, where if someone is so agitated, they're aggressive, and they have very little quality of life. Those are instances if the family is saying there's no way they're comfortable, I want them to sleep during this time until they die, then we can sedate them so that they're peaceful until they die. So that is something that's possible. Obviously, if we opt against that, then we'll just try to manage everyone's safety and that patient's safety. Okay, who knows what a Macy catheter is? No one ever knows what it is. Nurses at the hospital don't know what a Macy is either, because I was one of them. I had a hospice patient. It was one of those very difficult to manage situations. They came in to get an IV medication. We're running over. There. I was telling them we're gonna run over a little bit, so if they have to leave, they can leave. They've had really good questions. So a Macy catheter. I had a patient in the hospital who needed an IV, and they had this tube coming out their bottom. And I was like, what is this? Because it looked like a Foley catheter for your bladder, but it was in the rectum. And I was like, did they put it in the wrong hole? What is this thing? But I saw on the side Macy catheter, so I Googled it, obviously. And I found out what a Macy catheter is. That was my first. So even medical professionals don't care about it, so I don't expect anyone here to. But it is a wonderful tool. That is Brad Macy. We got to meet him like a year ago at one of our hospice meetings. He came to visit us. He's a retired hospice and home health nurse. And he had a patient with ALS who made him promise, do not ever send me to the hospital. I don't want to die at the hospital. I want to die at my home. Brad, please make that happen. And Brad got out there one night, and he could no longer take his medications, and he was having so many secretions that we couldn't just give medications to sit in his cheek and absorb through his gums, because it was just coming back out. And so Brad started to get creative, and he thought, well, what other options do we have to get this guy comfortable? So he called the doctor and he said, can I put a really big urinary catheter in his rectum and receive medication from the pharmacy to crush the medication and put in a little water and give it in his rectum? And the doctor said yes, and they did that, and they were able to get him comfortable. It seems barbaric, it seems kind of gross, it seems a little weird, but when you see it in reality, it's actually very discreet, because it's just a small tube that goes in there, and then we secure it to the leg. So when the family's giving it, it's just a little tube that shows on their leg, and we crush medication, put in a little water, give give it in there slowly, push a little water to flush it through the tube, and then their rectum absorbs that because it's part of your GI tract and it's actually more effective than oral medication that sits in your gums if they can't swallow. So that we use this a ton in hospice. So I wanted to touch on that today because there's a high chance that you'll hear about it if you know someone or you are on hospice. It's very interesting, and it's very helpful to keep patients at home and comfortable, so we use this a lot. It's also great if they're having seizures and you can't get medication in them, they can't swallow, yeah, there's just a lot of uses for it. Okay, our last topic is, I wanted to touch a little bit on post forms and advanced care planning. I have printed off a ton, so does anyone want a copy? I can just pass it around, and if you want one, you can take one. Let's see. Okay, there's gonna be two stacks. One is the advanced care planning packet, and one is the CPR guidelines. And it tells you what CPR is and what to expect, and is that going to be effective? Are you going to have long-term effects from having CPR? So that's good because that kind of helps you guide and have an idea of whether or not you yourself would want CPR. So you can take one of each. I'm not going to pass out the pulse form, but in this advanced care planning packet, it goes through what advanced care planning is. Essentially, it's what you want at end of life or what you do not want. Who here has an idea of things that you might want or not want that are willing to share? Do you have any specifics that you would want to share?
Well, my husband's an ER doctor, and so we actually have a very limited amount of care time, like less than anything on anybody's sheet. He only has us like a half an hour at the most for even any kind of life-saving measures because he sees what happens and he thinks the times on these sheets are way too long. And the one thing that he always wishes that people would know is that when people are in there trying to save grandma, as he always says, he wishes that people would know it's about you and not about grandma, and to remember that most people come in and they want to say goodbye to grandma, and so they do things to grandma that if they knew what they had to do to save grandma so they could say goodbye, they would never do it. And he said it's heartbreaking to see what they have to do to grandma just so that you can say goodbye to grandma or grandpa. And he said that there's no way when you're in crisis to be able to tell the family, please don't do that to your loved one, because that's all they want to do is say goodbye to grandma and grandpa. Or grandma's granddaughter doesn't want grandma to die today because it's her birthday. And you don't want to do that to your loved one, but you're in crisis, so you do it. And so he always says, that's why you need to do this for yourself, so that you've made that choice, so your loved one doesn't have to make it. Because if you've chosen that I'm choosing to do this, then you've already chosen it, and your loved one can't make that choice. You've already made it. And so then the doctor can do what you decided you wanted to do, and then it's not up to your loved one to make that choice, because you already said, please don't do CPR on me and break my ribs when I'm 90 years old, and now I'm going to suffer more so that you can come in and say goodbye to me, and I live like another hour or something crazy. So that's the most important thing, is that you do this stuff so that they have the okay to go ahead and do what's most important for you and your suffering in those last hours, and not for somebody to say goodbye to you in that last hour. And to always remember to always have said those things that you want to say to your loved ones all along, so that when you are in that moment, that's how it's been done. So that there isn't those unsaid words where the family's still saying, I need to say something, I need to, I still don't have that thing resolved. Make sure those things are resolved, because it can happen anytime.
Right.
So, so we have all this stuff done because of that, and we have a very, very short amount of time to even make that decision, because my husband thinks that this is way too long. Whatever is recommended for him is way too long. we have a very short window of time for, like, he just doesn't wanna be, all those things that can happen if you try to prolong saving a person and all the things that can come with that.
It's kind of like you should leave, you know, you should never go to bed without
Yeah,
saying,
yeah.
you know, without resolving your whatever
Yeah,
issue with your spouse
exactly.
before you go to bed, because they might not wake up in the morning and you might.
Yeah.
And the same kind of thing, when you leave the person, you need to make sure those issues are resolved.
Exactly.
Yeah. That's great. I mean, that right there is the crux of why we're having this discussion, right?
Yeah.
It's okay to have these discussions with your loved ones early so that they can say their goodbyes or have those hard conversations that they need to have, so it's not waiting till last minute. And you might notice that they're uncomfortable when you bring that up, but it's better for them to be a little uncomfortable now than to be panicking and you receiving CPR when you don't want CPR. So, that's essentially what this is. It gives you very pointed questions of what you would like to see or not see at end of life. Are you wanting CPR? Are you wanting a tube feed? Are you wanting a artificial airway? So it goes through all of those things. And then at the end, on the second to last page, it will say, it will ask you, do you want CPR? And if you say no, you do not want CPR attempted, and then next it will say, talk to your healthcare provider about pulse form. So when you get to that stage and you need a pulse form, you would talk to your healthcare provider and they'd give you this form. This is what our Confluence Health pulse form looks like. And it gets filled out, it gets signed by you, it gets signed by the provider, and it goes on the fridge typically, or it gets scanned into both into the Confluence Health records or hospice records, and then hangs in your home so that if someone calls an ambulance for you and they don't know that you have a pulse form, they will look at your fridge and see that's on there, and then they can follow your wishes. And same with your advanced care planning packet, that should get scanned in as well, because if, for instance, you're in the hospital for a longer period of time, they can pull up more details from you. Yes.
How do people know that this is there like a place that they can scan and find out for each person if they've asked to not have? Like
So,
if an ambulance was called for you, do they have access to that other than?
so if an ambulance is called, they're gonna look on your fridge.
Refrigerator, yeah.
Some people opt
And
to
where
get
is that stored? I mean, how do they access it?
the form.
Yeah.
It's on your refrigerator.
It's on your refrigerator.
Oh, you keep it in your home.
refrigerator, and you should also have your medication list on your refrigerator. It has all your medications on there.
Medications,
Oh,
maybe
I
your
see.
illnesses that you have,
First thing.
and the form should go on your fridge, and the doctor should scan this and have a copy of it. Same with your advanced care planning, they should scan this and have a copy in the system, so if you come to the hospital, they can pull it up, right? And they'll mark on your chart, full code or DNR. So full code, you want everything done, DNR, or it could be partial, where you want a little bit of a hybrid, you might have some certain criteria.
Thank you.
So,
And they'll still give you comfort method or measures no matter what. You know,
Right.
some people think that means they're not gonna give you comfort. We'll always give you pain meds and comfort and stuff.
Yeah.
That's not the same as do not, resuscitate or whatever.
Right.
Yeah. I wanna say, both my parents died of hospice at home and both had just wonderful experiences. Not that they were here to say anything about it, but they both got to die at home with hospice, and we had wonderful, as a family, it was really good, they both got what they wanted, and,
We've so far had really good experience with it
Oh,
too.
good.
And it's only been 3 weeks.
Oh, yeah, you're really in the thick of it then.
Yeah.
That's,
we were in another state, but, yeah, and they also had something called comfort keepers, which I don't know if they have here, which big comfort keepers, which is just like a paid adult babysitting, that babysat my mom for the last while. It was just like $25 an hour, and they came in and stayed with her all day, in between hospice. She was actually in hospice for a week, but we had comfort keepers for probably 2 years, actually.
wow.
And a lot of
That's
people
really
just
helpful.
told me that most people wait too long to start the hospice
Yes.
process.
Yeah,
Because they just don't think they need it, or they don't know what,
or they're scared.
yeah, and they don't know what's involved and how much help you can get. It's like, I was making a joke sort of about the pulse form getting lost, but it did.
Yeah, no,
We
I
had,
haven't.
I handed it to the social worker, she took it, she had the doctor sign it, it got put in the nurse, or in somebody else's box, it got scanned into the system, and then the dang piece of paper disappeared.
Oh, no.
And so that's why I filled out a new one yesterday.
Yeah,
It's exactly the same as the other one,
Right.
but as my brother puts it, that's the other issue. He's a retired firefighter and EMT, and he's used to coming in, being the guy that picks the people up off the floor, ground and
Right.
stuff like that. And he's going, we look for that green form. We don't look for a white piece of paper, because that's what they put up in the meantime,
right.
was a copy of the white copy of the original, that. But, so.
Well,
But
thank you.
where do I get a green form?